You can go ahead. It's fine, I got it.
That meeting's
Okay.
strong.
I got it.
Okay, so let's go ahead and get started. So my name is Ryan Selby. I work with Fisher & Paykel and a number of other product lines. And we're going to do a class today on pressure versus flow and the impact interfaces have when you're trying to give pressure versus flow therapy. And then that's going to take about 15 minutes of death by PowerPoint, and then we're going to do 15 minutes of an actual practical where I brought in a demo baby that's going to be able to demonstrate what happens when we put on a particular interface. We'll change out the interface, leave everything else the same, and see what impact that has on to that as well. We'll do that in a non-invasive CPAP setting and a non-invasive high flow setting, and we'll mess around with the flows. And then what that'll take a total together with the slides about 30 minutes, and then we're going to go ahead and go over proper positioning in a non-invasive CPAP on it. So any questions on that, please interject, raise your hand as we go throughout, and let's go ahead and get started. So we're going to go CPAP, nasal high flow in a NICU intensive care. Is this touch screen or strictly,
I would.
let's just go with that.
Yeah.
Okay, so first slide is pretty straightforward. Trends toward a more non-invasive support. So what we're trying to do, what you'll see nationally and internationally, is moving babies off of invasive ventilation as quickly as possible and move them to non-invasive support. So in invasive ventilation, that's when the BPD starts to build up. And we're trying to eliminate the BPD that happens when you do invasive ventilation with a baby. There's essentially two forms of non-invasive support. There's non-invasive CPAP, non-invasive high flow. CPAP, all of the various manufacturers out there have different acronyms, but they're all basically CPAP. Whether you're doing nasal IMV, IPV, PPV, a servo U with a NAVA, bubble CPAP, non-invasive CPAP, they're all CPAP. They all require a specific pressure, or they're trying to create a specific pressure to reach the alveoli of the baby. Babies who require a CPAP at very minimum are typically 23 to 28 weeks. They can't maintain their own FRC or their own functional residual capacity, so they're trying to create a CPAP so that their lungs don't keep deflating whenever they exhale, right? So that is basically what CPAP is doing. In nasal high flow, a baby is able to maintain their own FRC, and now we're just trying to wash out the CO2 so that the air they breathe in is the exact concentration of air we want them to breathe in, okay? So that's the two in CPAP. When we're talking CPAP, when we do the demonstration, I get this question a lot. I'm going to be doing a demonstration with the bubble CPAP. Everything I show you on the bubble CPAP will also count if you're using servo U or a Draeger, NAVA, NIMV. It's going to have the same results because the pressure is a specific thing. We'll take a look at that. Okay, let's see if I can down arrow this. Yes, we can. So since I work with Fisher & Paykel for this, I brought a Fisher & Paykel bubble CPAP system with me and a Fisher & Paykel nasal high flow system with me. But if you use Vapotherm or if you use any other product, it applies the same for what we're going to show you today. Okay, so let's talk about the interfaces. When a manufacturer creates an interface for whether they're doing a specific pressure or specific flow, they have to reach certain criteria in order to be a correct interface. When they do a CPAP or a non-invasive interface, it has to have large bore tubing, 100% occlusion of the nares. So when you see a device like this or a device like this, this was not intentional to torture the nurses and RTs and torture the baby. It was designed like this in order to have large bore tubing, 100% occlusion of the nares. If you don't have large bore tubing, then your manometer is going to be wrong. If you don't have 100% occlusion of the nares, your CPAP will be lower, about 40 to 80% lower than what it says on your manometer. So, if you have 100% occlusion of the nares, not less than 100%, a full 100% occlusion of the nares, plus large bore tubing, then the reading you're seeing on your manometer will be accurate. It will be accurate. So if your manometer says I'm giving this baby 5 centimeters of water pressure, that is actually what is hitting the alveoli of the baby. I brought with me a bubble CPAP manometer, so when we set up my demo baby, we're going to take a look at that. We're going to measure that with what it says on the manometer and what it says with the computer. Okay. In high flow, we want different criteria. Very narrow or restrictive tubing and an unsealed interface. How much? Typically about 50% occlusion or less. 50% occlusion or less. There's a reason for that. In a high flow setting, the cannula becomes the protective shield for the patient, because in a high flow setting, instead of a dual limb system like you use in your CPAP, it's coming down to a single limb system. And so now if we're driving in 6 liters of flow, this protects the patient from getting all 6 liters of flow into their lungs. So the resistance of the tubing and the occlusion is the shield, but you also have to have a high enough flow in order for the air to reach down into this area and wash out the CO2. So imagine this, you're spraying down your patio and you've got your hose, and if you need it to shoot down a little further, you just put your thumb at the end of it, it kind of pushes it down further, you're trying to increase the pressure. We do that with this by increasing the flow. Just to give you the punchline, in the studies, high flow efficacy is about 4 to 8 liters of flow. If you're doing less than 4 liters of flow, you're given low flow. You're given low flow. So we'll take a look at that. All right. Next slide. So mechanism of action in CPAP, we're looking for continuous positive airway pressure. We're giving something where we're giving a basic FRC for the baby, right? So if I set 5 centimeters of water pressure, then I want the baby to get 5 centimeters of water pressure. Not less than 5 centimeters. We want the baby to have 5 centimeters of water pressure.
On which level, I'm sorry? The 5 centimeter of the water pressure is on the throat of mouth area, long bronchitis?
We want it all the way down. We want 5 centimeters of water pressure within the lungs. That's what we want. And what we are measuring now, which we don't have, is our babies don't have a computer screen on their chest that's telling you how much pressure they're getting in their lungs. So the only thing that we can measure is what the manometer tells us. We're going to take a look at that.
But that's not the accurate one. The baby really gets in their alveoli level, right?
Right. It's not accurately, particularly if you use a cannula. So, and I'll show you why that is. But basically, when this interface is on, it will give you a reading when there's a stopping where the air can't go any further, right? It stops basically if it hits the bottom of the lungs, the air creates a pressure, and now we've created a CPAP, and you get a reading that says, okay, the air is not going any further. This is how much pressure that's reached at. In a cannula, just to get in front of it, it no longer is reading down here, it's reading back here. It's reading back here, and that's why you're getting a false reading. We're actually going to see that visually. But we'll get that to in a minute. Okay, in a nasal high flow, instead of looking for that specific pressure, we're just looking for something to wash out CO2, right? Okay. Real quick on humidity, there's a lot of discussion on humidity, why we provide optimal humidity. Optimal humidity can only be achieved at 37 degrees Celsius on the heater. That is what's considered 100% optimal humidity. It's a completely different talk that we can go over as far as what happens when you decrease that temperature from 37 down to 34 or 31. But it does have an impact on mucociliary function when you decrease the temperature simply from 37 down to 34 degrees. Where after about 15 minutes, the mucociliary function starts to slow down. And after about an hour, the entire area starts to dry up and pathogens are no longer being moved along just by that simple decrease of temperature. The other thing that happens when you decrease is body's homeostasis is when air comes in that's too cold for what it wants, it immediately tries to heat and humidify itself. And with the baby, what are they using to heat, humidify? their own temperature and their own moisture, and we're trying to prevent them from doing that. So 37 degrees on that. All right.
I have a question about this. You guys have two sitting over there on the Fisher for count,
Yes.
right?
Right.
Invasive and non-invasive.
Right.
Okay. Our nose, mucous membrane, our nose are providing a humidity in the same time when what air goes in,
Right.
correct?
Right.
Now, if I'm using 37 degrees, I know it's a body humidity temperature, but our nose, isn't the 37 degrees a bit higher from our nose?
Right. So let's talk that. So we actually want to get all of our patients, to include our adults, to 37 degrees. The reason why we have 31 is because our adults can complain about it. Now our goal is to get them also to 37 degrees because there's a lot of data that it is therapeutic for them to be at 37 as well. But because they could bark back at you and say, okay, that's too hot for me, you need to turn that down. The goal is, even if you turn it down, is to get them up to 37 as well, because even though this is, yes, it starts to moisturize it, in a baby or a NICU setting, they don't have the spare energy or the spare moisture to be able to heat up air. So what you're trying to, because if they were in utero, all that temperature, all that moisture is already provided for them by the mother. So when they come out premature, they don't have that excess heat and humidification themselves to heat up that air. In an adult setting, we've got a lot of spare stuff, and so you can play with it a little bit more when they complain about it, but you still would like to get them up to 37 as well. We do have a heat humidification CEU that speaks on that. I would love to come back and talk over that one. It's about a 30-minute to 60-minute class, or I can also show you the data as well after this.
But I tried it myself.
Oh, it's hot. It is hot.
I mean, if that's hot for me that much when I put it in, I don't know what they're gonna do to those babies.
It doesn't cause damage. It certainly is hot for them, but it's not damaging them. But what it does is it seems counterintuitive. The damage is caused when it comes down to 31, because the mucociliary function starts to dry up and they start losing body temperature. So yes, it's warm, and yes, it can be uncomfortable, but that is the temperature that it has to be in order to be therapeutic. Okay. Coming down. There are 64 studies out there that compares high flow and CPAP. In all 64 studies out there, all of the CPAP interfaces are large bore tubing, full occlusion and airs. In all of the studies for high flow, all of the interfaces are partial occlusion and airs, restricted tubing. There is no study out there that's been approved by the FDA in using of any kind of cannula in a CPAP situation, or has demonstrated any efficacy in a CPAP situation. Okay, so what we're going to talk about with this data, so we've got tons of data, 64 publications, right? Comparing the two. The question is when do we use CPAP? When do we use high flow? Okay, so there was a meta-analysis called the Cochrane Review, where they basically looked at some of the key studies out of those 64 to kind of determine for nurses and RTs, okay guys, when do we use CPAP? When do we use high flow? The easy one is basically in the first 28 weeks, that's a CPAP kit. That one is really not up for dispute. A lot of those kids don't have a good FRC, so that CPAP could either be invasive CPAP or non-invasive CPAP. The goal is to obviously get them to non-invasive CPAP to lower their BPD. Where the discussion starts to waver is between your 28 and 32 weeks, or basically your 1,500 gram kids, roughly. There has been a percentage that actually do start to do well and transition to high flow. So the high flow kids in that group will have about a 70% success rate when compared to a bubble CPAP or other CPAP group, which is about an 80% success rate. So there's a difference there. And those who are on high flow, if they failed on high flow, could be rescued with CPAP and the end results were the same. However, what I'm hearing out there in the field is that 10% fail rate is too high. Because when a baby fails, maybe you can rescue them with respiratory care and their respiratory care is doing fine, but how much energy do they lose during that failure time? So for the nurses, they're losing heat, they're losing moisture, they're losing the ability to feed. All these kinds of things happen with the failure. So a lot where people are moving towards is CPAP seems to be a 23 to 32 week, I'm comfortable with that, post 32 weeks is high flow. Okay. I want to talk about this one where it says what was the statistical differences between high flow and CPAP. There was no statistically significant difference in the rate of treatment failures between high flow and CPAP when compared against each other. But remember, in the nasal high flow studies, their rescue treatment was CPAP. It was CPAP, and then it was the same at the back end. So that's almost like your treatment failed, but then you used the one that was better and everything was fine. So that's a little bit dodgy for me on that one. No statistically significant difference in reintubation. That's important. So if you do start on high flow and you rescue with non-invasive CPAP, you don't have to jump all the way down to intubation, which is lovely. No statistical difference in the outcomes of pneumothorax. That's very important because doctors have it in their mind that when they do high flow, they're going to increase the risk of a pneumo because there's so much flow coming out of that. And we'll look at that and see why that's not an issue. And then the reason why people use cannulas is there is a significant reduction in breakdown when you use a cannula. This is why cannulas become very popular, is because you start to see all of these breakdowns and these happies in the area, right? Okay, that is important to look at, but remember, BPD and FRC first, breakdown second. Got to make sure that the efficacy is first, and that's what we're talking about with the big interfaces. Okay. We talked about that. So, in the studies, in those 64 studies, CPAP was measured typically from 5 to 8 centimeters of water pressure. That's not unusual, right? Everybody would agree that's probably what we're doing with our CPAP. In a high flow, the studies were from 3 to 8 liters of flow, and true efficacy wasn't really seen until 6 to 8 liters of flow. 6 to 8 liters of flow. Now, a couple of years ago, we came out with saying we need to get everybody to 6 to 8 liters of flow, and that was a non-starter. Every hospital was like, I can't even get the doctors to go past 2 liters of flow. 6 to 8 is not going to happen. So, in the studies, efficacy is also 4 to 6. If we could just get the babies to 4 to 6, maybe 6 to 8 down the road, but 4 to 6 also demonstrates a level of efficacy in those studies. Okay, so that's it on that portion. Let's go ahead and set up. What we've got here is baby live. So let me see if I can make this work.
Is there any, even when we're giving like 16 liters flow to the high flow, that still creates some of the pressure to help the FRC, or it's just a washout?
What's that? Say that again?
If I'm giving 6 liters of high flow.
Am I giving CPAP as well? Yes.
Okay.
You are.
Now, with that, there's a measurement done, like for instance, on a 6 liters of the high flow, how much CPAP I'm generating in alveoli, not alveoli level, it's not hard to measure there, at least in a bronchiolized level.
So it's variable. So the reason why when we say 100% for our interfaces is because it takes the variability out. So with one baby, let's say you set it at 6 liters of flow, but you don't know exactly the occlusion you did on your prongs. So how much CPAP are you giving to that baby? And let's bring a completely another baby in and do the exact same thing. How much CPAP are you giving to that baby? So by using 100% occlusion and errors, using a bias flow system, if you're getting a 5 centimeter reading on the manometer, that's 5 centimeters going into the lung of the baby. We're trying to take the variability out. In high flow, we're good with variability. In CPAP, we want a specific. Gotcha. Okay, so let's, I'm trying to open a web browser, Sylvia.
You can try.
Oh, that guy?
Yeah.
Okay, so let's go to babylive.com. Baby. If this doesn't work, we'll just use my iPad and you guys can all climb around. Yeah, it worked.
Oh, nice.
Can you believe it? Okay, so what we have here is we have baby lymph. And this basically, it looks like a baby because it's got a face on it, creepy baby face. But what it basically is, it's a lung. So this lung in here has the same about cc capacity as a 750 gram baby. So we measure that. What this allows us to do is when we run our interfaces in through the nose here, we measure what's going on in the lung where it reaches the bottom of the lung, and then we get a reading on an XY graph. So this XY graph you see here is just communicating with my guy here. So I'm going to start off with a basic CPAP interface, and we're going to go ahead and do get a baseline, see what CPAP looks like. And Tara will be editing this video, so make sure it's not so boring for the people who see it on YouTube. So I've got 100% occlusion of the nares. The pacifier that you see here is going to represent mouth leak. Now if you look at this, I'm going to have it set at 5 centimeters of water pressure. This here is a bubble CPAP manometer from DRW. And bubble CPAPs typically don't use manometers, but they're becoming more and more popular because this one comes with an alarm that allows you to determine if the pressure is too small or too low or too high, whether you have a leak or not. Okay. So I have this at 5 centimeters of water pressure. When I look at my manometer, it says what? 5. When I look at the screen, it says what? 5. Now, when we look at the screen, we also have these vibrations. That's the oscillatory effect for the bubble CPAP. That's what we're going for, obviously, for the bubble CPAP. That's that vibration, plus or minus 1 or 2 centimeters of water pressure. So you can see sometimes it jumps above 6, sometimes it drops below 4, but the mean is about 5. Now, to show you that this is not any kind of magic, when I increase this to 6, this should go to 6, and this should go to 6. Which it does. So the reason why we're getting an accurate reading is I have 100% occlusion of the nares. So the air is hitting the bottom of the alveoli. If you were to look at the lungs of my baby right here, it's hitting the bottom of the alveoli and it's flickering here. And that's the reading that we're getting here. When you have a mouth leak, and 30% of your kids are losing pressure through their mouth, regardless of the system that you're using in a CPAP system. The problem is when you have a mouth leak, you need to know that you have a mouth leak. So I'm going to take out this pacifier because this is what happens when you have a mouth leak. Now, in this system, it's no longer bubbling because I have a leak through the mouth. So when I have large bore tubing, 100% occlusion of the nares, everything is, the leak lets you know by the lack of bubbling, right? So this baby is down to 0.5 centimeters of water pressure. That is not nearly enough. So we're going to go ahead and plug that back in, and that's what it should look like. So let's go ahead and stay that data. Now, in the spirit of fair play, I'm going to use a system from Gettinga that's also designed for CPAP with the mask. They follow the same concept. Large bore tubing, 100% occlusion of the nares. They're just doing it through the mask. So that should be the same, right? Because I said if you just follow those two criteria, it'll be the same. So we're going to go new. And it's the same. It's the same. So the interface design, how it fits on the face, really doesn't matter as long as you have large bore tubing, 100% occlusion of the nares. When we take the pacifier out of their mouth, it's the same. So let's go ahead and put that in there. We're going to stop. Now, what we're going to do is find my Y adapter that I had around here. And we'll edit this for brevity as well. I had a Y adapter here, Tara. Would you mind helping me find that?
That's it. No.
It was just fine right here. Well, I got it.
There it is.
Oh, yep. on
Oh,
the other
it's
side.
right by the end of it. Thank you. Okay. So we've all seen these. because we've all seen these. First thing you'll notice once I plug in the ram cannula is what's my bubbler doing? It's bubbling. What does my manometer say?
5.
But it's not on a baby.
Right.
So why are you getting a reading of 5?
The resistance.
The resistance. So we have Los Angeles traffic coming in this direction. Now we have road construction right here. So we have a bottleneck right here. So your manometer isn't reading the stoppage of the air at the bottom of the alveoli. It's reading the stoppage of the air here. And it's telling you you're giving the baby 5 centimeters of water pressure. And if I include the prongs, or if I bend the tubing, this still says 5. Nothing changes when I mess with the interface itself. So the question is how much actual CPAP am I giving to the baby? So once you put the cannula in, it says with these cannulas, they say they want you to do like 60-80% occlusion of nares, right? So you have a leak. If I was to give you a water hose and I punch a bunch of holes into that water hose, the pressure coming out would decrease. Same concept with a leak around the nair. So let's look at this. The green is your cannulated CPAP. So how much CPAP are we giving? 1.5. But what does my manometer say? 5. So I'm giving the baby 1. What about those vibrations?
Oscillation, but oscillation is
It's
not
oscillating about 0.25, 0.10. So now all of that has been eliminated. So but because this is still bubbling, because this says 5, vast majority of the time you will never see a chin strap on a kid who's on a ram cannula, on a nasal IMV or a bubble CPAP. So this is what it looks like when you don't have a chin strap on a cannula. But it's still bubbling and it's still telling you 5. So the next logical answer is we're going to titrate to effect, right? We've heard that. So let's increase the CPAP to 10. Let's increase the flow to 12. Now my manometer tells me how much am I giving? 11. How much have I moved up the actual pressure to the baby? Because they're losing all the pressure out of their mouth and through the side nose with a 60 to 80% occlusion. Okay, so that's when you start getting the variable. But the information you're receiving, whether it's nasal IMV or bubble CPAP, changes dramatically. Any questions on that? Okay, so in a high flow setting, let's stop this data. Now we're looking at something a little bit different. We're going to turn him off because in high flow we're not going to be able to use our manometer. In a high flow setting, we have a single limb system. So now we want to make sure that whatever comes out here safely goes into the lungs of the baby. So we're going to start with a Fisher and Paykel high flow, and we're going to use one that I know is roughly 50%, like so. What flows do you guys typically do when you do high flow, when you start with?
2 liters.
2 liters. If you do 2 liters, it's pretty standard in the state of California, right? So let's take a look at 2 liters. We're going to clear this, and we're going to go new. Okay, the red is 2 liters of flow. So the question is are we meeting the inspiratory demand at 2 liters of flow? Or are the prongs becoming somewhat of an obstruction at that moment? Are they having to pull in air themselves when they're breathing at 2 liters? So in the studies, remember we wanted to get to at least a minimum of 4 liters of flow. Now to answer the gentleman's question, when the high flow goes up, sometimes you're going to get some CPAP that goes up as well. So we still want to measure CPAP to at least see that we're doing something. So let's increase this to 4 liters of flow. We'll stop off at the minimum. So now we've got a little bit of response. You can see our CPAP is up. We're starting to wash out CO2. Baby cries. Nurse needs to know that this is safe, that if I put a pacifier in the baby's mouth, because the baby's crying, the CPAP doesn't go up. Well, it goes up, but it doesn't go up, that's unsafe. So we were at 5 centimeters of water pressure at bubble CPAP with all those vibrations. At 4 liters of flow with the pacifier in the mouth, we're at 1.5. I feel comfortable with that. This is a very small baby. It's a very small set of lungs. That's good. Let's go ahead and increase this to 6 liters of flow. So that's 6 liters of flow, and we're still below 3 centimeters of water pressure. Still deemed safe. This is typically when you start getting into that combination of washout and a little bit of CPAP, but only when the pacifier's in the mouth. If I took the pacifier out, it would still drop down with mouth leak, but at least we'd be getting that washout. Okay, so I thought that the red cannula, in order to demonstrate that cannulas are safe, it can't be subjective. Meaning, if I chose the red cannula and thought that was 50%, and Tara here thought that 50% was the next size up, does that have a big impact on what I'm doing with the kids? We need to demonstrate that it's safe between the two, because it shouldn't be so subjective that 2 different people do something, it has a large impact on the therapy. So let's stop this data. I'm gonna go from a red cannula that was about 50% to a yellow cannula that's about 60%. So with the 60% occlusion, the CPAP should do what?
Increase.
It should increase. And it does, but not a lot. So we know that if we stay within the approved NICU cannula sizes, that it's going to be effective if we're using what is recommended in the studies. What happens if you go into the 60 to 80% range of a cannula? Let's take a look at that. So I'm going to start with the green of a RAM cannula. If you guys do cannulated CPAP with a RAM, this is about 60% occlusion. So it should be about the same as the yellow Fisher and Paykel, because the occlusion is what determines your CPAP, right? So we'll go new, and it's about the same, right? Everything's working well. But let's say Ryan came in and used the green cannula, and the next size up for RAM is actually blue. And Tara wanted to use the blue one. Wanted to use 6 liters of flow because the doctors say, I just heard that we're supposed to use 6 liters of flow and high flow. Just came back from a big meeting. Let's start that.
No changes.
No change. So this is about 80% occlusion with your cannula. What are we at? Big change. This is why 50% occlusion for high flow is what was studied. Is because once you go past 60%, it exponentially redoubles on itself. And now you're starting to get into CPAP that people are afraid of with the high flow. So 100% occlusion in a CPAP setting takes out the variable, meaning if I give 5 centimeters of water pressure, the baby gets 5 centimeters of water pressure. 50% occlusion in a high flow setting makes it safe for the patient, and you could use those higher flows.
And usually when our patients are not doing good, everybody going for the bigger size.
Right. But let me ask you this question. So why does the RAM seem to be working on the nasal IMV?
Why is it working?
Why is it working?
Because we're using the bigger sizes.
You're using it with the bigger sizes in a bias flow system, and what are you setting your flows at?
The flow is automatic. It depends how much flow is needed.
Right, so it can be 8, 9, 10, 11, 12. So basically what you're doing is you've taken the RAM and you've turned it into a really awesome high flow. And you are already giving the high flows that are being recommended. So you're taking out, the CPAP. We've already demonstrated that the CPAP's gone down, but now they are getting those flows that they've been talking about. You're just doing an end around to do it.
Right.
So that is why the RAM cannula is working. But if you have a baby that, if you're finding that they're failing on that nasal IMV and you're having to reintubate, and then they're failing on nasal IMV and then you're having to reintubate, if you're doing that yo-yo, then that stage of 23 to 28 or 23 to 32 weeks, you're not hitting their basic FRC with non-invasive CPAP. The only way to do that is with an interface that can take that variability out and lock that in. Oop. Okay, so how much time do I have? Oh, I got a few
The
minutes.
problem is we as a clinician or we as a consumer, whatever you call us, we're getting confused. If Dr. Ramachandran comes in over here, lecturing you over here, he will prove his RAM cannula much better than interface. And then you come in and telling me interface is better than RAM cannula, and I don't know what we should do and who we should believe. You know, it just makes it very, very hard.
That's true. The RamCam is not approved by the FDA.
And I know that. I know
Okay.
that, but I was in one of the lecture when children was here, and he had some data too. I mean, he had some screen friend of us, and
Absolutely.
he proved it the way it's working too. And then now, I know I used interface for so many years. I mean, I know that works for sure. But the logic behind it when he was explaining it, he convinces.
I understand that. I don't know how to I don't know how to speak onto that.
How are we gonna? I mean, how are we gonna? I mean,
Well,
this-
I do think that FDA approval does have to have some kind of weight.
That's correct. Then why they're allowing? I mean, clinically wise, if you look at all NICUs are using RAM cannula right now.
You know what we use at RAM cannula, we use it by baby weight, not because we want it. We can put for small baby big cannula. So we look how baby is weight.
So what
Yeah,
weight do you
right.
start
Yeah,
using
this
on the
is-
cannula?
Yeah,
Yeah.
it's fine.
No, but
It's not-
what weight do you start using the cannula on? Well,
When
what's
you get it
what's
when
the
you're- How can we exhibit it?
We've done it
Doesn't
on
matter.
600
Oh, I see.
micrograms.
Yeah, but we
Yeah.
use it even before, but we if baby like let's for 600 grams, we use it white cannula, after green, after blue, and
Less
orange
than
is
700
more.
is that.
Yeah,
You
we
do.
have range. We have range.
But that's not right because what happens is anatomy of each kids are different.
Mhm.
By the weight, somebody will be a big weight and have a small nose. So somebody's going to do it a less weight and really have a big nose. We have to look at
You
the
can't-
observe
you
it
can't
over
put
there
a
on the
big
nose,
cannula in a
how much
small
obstructions we have and how much we don't.
Mhm.
Which on those RAM cannula we could not occlude it completely.
No.
Yeah.
It's supposed to be like what 60-80% or
Right.
something.
And that's very important.
We try to.
So, and I understand all those things, and I really shouldn't be talking why RAM is doing what it's doing or what it's demonstrating on that.
But we as a clinician,
Yeah.
we hearing all those data and we see all those people are presenting their data, and then in the end we're getting confused, you know.
Well, there is the Getty's study, which is a clinically reviewed study where he basically took the cannula, and it wasn't just directed at RAM cannula. He basically just measured what would happen on if you had not so much the cannula, but a leaf, an 80% occlusion, a 60% occlusion. How much would that decrease the CPAP? So if you were at that 60 to 80%, it was a decrease of 40 to 80%
Physics-wise,
CPAP.
it makes sense. you're
That's
right.
just physics at that point. Yeah. Okay, I don't want to run too long for the next person to talk. Let me real quick go over on positioning with the interface. If you guys start to see this, I get this question a lot for what's proper positioning, how this should look. Since I only have a few minutes, let me go over it relatively quickly. I do have a Tortle bonnet on here. This was designed by Tortle in order to help keep the patient midline, so you're not using that sock kind of technique that's going over the head. In the spirit of time, I'm going to leave this Tortle bonnet on. It also can be used with the Fisher and Paykel interface, and it's a nice little round kind of horseshoe here. These are kind of popular because they help babies stay in a neutral position during IVH, but also cut down on toaster head, which is a big deal within the NICU. So when we are using these interfaces, when you're choosing a prong size or a mask size, as we discussed, it's important. Let me turn this down because it's too loud. Go for 100% occlusion of the nares. What happens is if you don't get 100%, not only do you not get a CPAP, but with these interfaces, whether it's a Fisher or Paykel model or the other model, you start getting breakdown. And these are a lot more exacting to use because they are so big than compared to any cannula. If a cannula could be made to work as effectively as a CPAP interface, that would be great. But based on what we as a company feel right now, hasn't done that yet. Okay, so I have my interface here. If you use this interface and there's two of you, please try to have two people put this together. One nurse is stabilizing the baby and the RT is putting this on. If the RT and the nurse are both trying to put the interface on or the bonnet on, there's too many hands. So the best thing, the feedback I always get from nurses and RTs is, well, your baby doesn't wiggle. Yes, your baby's gonna wiggle. So the nurse needs to stabilize the baby and hold the baby in place. With these prongs, since they are so large, using a little bit of saline at the tip will go a long way to get them into the nose, or what you consider to be baby safe lubricant, whether it's like Aquaphor or whatever. Once this goes into the baby's nose like this, and my baby is being very cooperative, nurse should just take their index finger and hold that right like so, and hold the baby like this. This is the best thing the nurse can do at this time. Because if the nurse was standing here for the next 2 weeks, this is the best CPAP the baby's gonna get during that 2 weeks. But we don't want them to have to stand there for 2 weeks. But holding this here just ensures that the RT or whoever is putting the bonnet on can slow down. They don't have to rush and put it on at that moment. Okay, so when we put these tabs on and bring it over the top, you guys have seen these straps here, right? You've put these on. The problem with the straps is what happens is as soon as one strap goes into this hook, whoever put that strap in immediately tightens it down.
Yeah.
And then the other one takes their strap and puts it into this hook, like so. And then they tighten theirs down. And none of this is on center. What's supposed to happen is nurse or RT, whoever's doing this, holds this in place, and only one person tightens this. I'm gonna lift this in the air so you guys can see it. So that you wanna center that blue glide bar up and bring it down. When the strap is on, it should be below the ear, down by the jawline. There's 3 reasons for that. If you think about the other bonnet, if it's down by the jawline, first off, it acts like a football helmet and holds the football helmet in place so it doesn't slide that direction. Number 2, you don't have a strap over the ear and the cheek, holding the ear and the cheek to the face, causing undue pressure or collecting any moisture in there. And then number 3, it helps to hold the prongs out. I have some of that Neotech NeoSeal for the prong, but you still want to see a little bit of the prong sticking out like so. Here is one point of contention that a lot of people have, is when we run the circuits out, believe it or not, F&P recommends for all their circuits to go through the side corner holes of your incubators and never through the center opening. If you use it through the center opening, that's the rainmaker, and I'll show you why. So let's assume that this is the center opening where my hands are at. Can you guys see where my hand is? So let's assume this is that slide that we run the circuit in and runs out and then goes back to whether it's our CPAP or our ventilator or whatever we're doing. And if we're honest with ourselves, it kind of looks like this, right? So what happens is we have heat humidification are coming down this nasal tubing, and what's it doing coming out here is it's starting to cool. And as it's cooling, condensation is forming. And where does that condensation go to? It goes to the U-bends that are built in the expiratory limb. So that if ever the baby turns his or her head, you get a voltage and the water is it will go down like so. And if they could take the circuits and put it all the way down at the bottom of the slide, that would be great. But vast majority of the time when you come back, it starts to rise up and looks like so. In the side corner hole, there are 4 distinct bottom opening positions that are designed for respiratory circuits to run out of. And the reason why you put it there is no matter who puts it there, it can never rise. It is a finite, specific thing. And instead of using circuit holders, because circuit holders have a tendency to do this, and now you're creating that apex where the water flows into the baby's face, use 2 blankets, place it under the temperature probe. This temperature probe is the heaviest portion of this entire setup, and you want to make sure the baby doesn't feel it. So we bring in a lot of circuits in here, put the blanket underneath the temperature probe so the baby can't feel that. Okay. The 4 most common pressure points with this interface or the Hudson interface are as follows. Septal breakdown. What causes septal breakdown? When the prongs are too small, what ends up happening is we push this in to get a seal because it's not bubbling, and now we push it up against the septum, and since it's small, it starts to wiggle. What you want it to do is have 100% occlusion of the nares and be able to have that separation with 100% occlusion of the nares. The problem is once you size a prong, the baby's gonna grow. So you gotta grow the prongs with the baby. Baby's gonna get bigger, so it's not a one size fits all for the rest of its term. Forward, what if you see a breakdown right here, a triangle right around the nose? What's causing that? Mask. The mask. And that is almost always caused by RT taking a strap on this side and the RN taking the strap on this side, and there's this tug of war just to get that on, and they put it down and the mask is smashed down. Only one person should tighten this with the mask, making sure it's basically kissing the face just enough until it starts to bubble, or you get a reading on your ventilator that says everything is okay, and then stop. The third and most common one, if you guys have used this interface, is breakdown right here. Anybody know why that happens? It's because of the mask. It's because the mask is cantilevered down. If you've used our interfaces, you've noticed it comes with these foam strips. If you've ever seen these, we'll have to retrain on that. When you use the mask, you always have to have at least one foam strip in there, and that brings it so that it stays parallel with the face of the baby. If you didn't know that, that's okay. That's our job as a company to make sure to train that. But the one foam strip with the mask will make sure it stays parallel with the face. And then the fourth and second most common one is you see redness here running down to the face of the baby. What causes that? It does. Why though?
No pressure.
So the reason why there's pressure coming here is typically what you'll see is you'll walk into a bed and it looks like that. And so this temperature probe is weighing down. Can you see that okay? This temperature probe is weighing down, and the circuit's weighing down. The baby's turning his or her head, and the blankets are at the foot of the bed, or there's nothing in there at all. So you always have to take the weight off and put it in like so, as far as that's concerned. That's my time. Any questions?
Can the temperature probe be outside of that?
Thank you for that question. That it was the biggest question I get. Can the temperature probe be inside or outside of the incubator? The answer is it could be either, but we would recommend it be inside. Why? So when these first came out, the recommendation for Fisher and Paykel was to have the temperature probe outside of the incubator, because incubator settings used to always be set at manual mode at about 36 to 37 degrees Celsius. And that would cause haywire with the temperature probe, and you get tons of rain out. Now all of these awesome incubators that you guys have, everybody uses baby mode. And the temperature within that incubator is typically doesn't go above 32, 33 degrees Celsius, and it doesn't cause haywire with the temperature probe. The reason why we want them inside the bed is when you put an extender here, what are you doing?
That's more on wire, please.
Yep, so it's not a heated wire. So the temperature starts to drop and the humidification starts to create. So for every 2 inches of unheated circuitry, temperature drops by 1 degree. So air, when it comes out of here, comes out at 40 degrees. So that by the time it reaches the baby at 37 degrees. Since we are creating a dew point at 37 degrees, then anything less than 37 and you're gonna get rain out. So if I had 6 inches of circuit, unheated circuit here, I've got 3 degrees of temperature dropping right here, 3 more degrees, we're at 34, rain out, rain out, rain out, rain out. So that is the why of having the temperature probe inside the incubator.
And also, we don't use the non-invasive temperature on the Fisher Paykel at all with the babies then, right?
Yeah, so invasive mode for 37 degrees is recommended by F&P. We don't go as far as say you have to, because it's still up to the clinicians in the hospital. It's recommended by Fisher Paykel for all your babies who are in a NICU to do 37 degrees Celsius.
Right.
All right, I appreciate you guys. Thank you very much.
Thank you.